Good day. How's all the family?
Good morning, everyone. Welcome to Pediatric Grand Rounds today. Thank you for joining me. Today's speaker is Dr. Hugh Kraft, a general pediatrician from Postal Drive practice. So can anybody tell me, so Dr. Kraft has the distinction of being number one. Why is Dr. Kraft number one?
He's the oldest.
Any other answers?
Yeah. Siamese twins. Conjoined twins.
Not exactly. So he has the distinction of being the longest serving member of the Department of Pediatrics, number one, and not retiring anytime soon, I think.
It's taken a long time to get here, so I'm not going to retire anytime soon.
Yeah. All right. Dr. Kraft received his training at UNC. He did his medical degree, residency, and completed a master's in public health at that time. He completed his fellowship at Duke in Neonatology. He came to Roanoke in 1985 and worked in the NICU. He then went on to work in the intensive care unit and went on to practice general pediatrics at the Gen Peds Carilion Clinic, which later on became the Postal Drive branch of Gen Peds. He got a little bored a few years ago, so he decided to do a course at Johns Hopkins on the history of medicine, which he is about to complete. And he teaches the history of medicine as a course to the M4 BTC SOM students. Please join me in welcoming Dr. Hugh Kraft.
Oh, good morning. I want to be able to do at least one grand rounds when nobody's wearing a mask. It seems like that's been going on forever, but it's great to be here. Actually, I gave a version of this talk about 25 years ago, and we were still using slides then. But I don't think anybody in the room was here for that talk, so I think I'm good. And so what we're going to do, we're going to kind of go back in time and look at what were some of the key early developments that kind of have led to what we see when we go into the NICU now. And I don't have any disclosures, so let's get started. And we're going to go back to France, and specifically Paris, in about 1880. And France during the 19th century was one of the world hubs for medical education. If an American physician wanted to be well trained, they went to Paris or Vienna or to Edinburgh. And particularly in the first half of the 19th century, Paris really was the world center. Laennec and the stethoscope, Bichette was kind of the father of anatomic pathology. Pierre Louis, if you want to read, if you're interested in epidemiology, he was really the first clinical epidemiologist. He demonstrated quite clearly that bloodletting did not do anything except maybe make the patients worse, but it took 60 more years for it to go out of style. So interesting person to read about. Claude Bernard and all his early studies in physiology that really laid the foundation for medicine becoming more of a science. And then, of course, Louis Pasteur in microbiology. So there was a lot going on in France in the 19th century. It waned a little bit in the latter half, but particularly in Paris in the late part of the 19th century, obstetrics was still a very prominent, well-respected field and a place where people went to study. And one of the giants at that time was Professor Stefan Tarnier, and he was kind of the father of modern French obstetrics, and trained an entire cadre of young obstetricians. Interesting, obstetricians in those days, they took care of the babies till they were about 2 years old. So the pediatrics was really not established as a specialty at this time, at least for infants. And one of his proteges was Pierre Boudin. Has anyone heard of him? If you've read a little bit of pediatric history, you might have heard of him. And he was one of Tarnier's residents and became really his protege over the next decade. And Tarnier designed the first, what we consider kind of the modern version of the incubator. And it said he got the idea for this. He was walking through an agricultural show in Paris, and he saw incubators that were keeping young chicks warm, and he thought to himself, why couldn't we do this for infants? And so he had a friend at the Paris Maternity Hospital design an incubator for him, and it really consisted of a box, and then there were warm water bottles under here, and air circulated in and around and up and out, and the baby was on a little platform in the middle of the incubator. And so this is really what we'd consider the first modern incubator. There were some earlier versions of devices to keep babies warm, but this is really the first enclosed incubator that you could look at it and go, it looks a little bit like what the modern incubator looks like today. And he reported a series of over 500 infants with birth weights 1,200 to 2,000 grams that were cared for in incubators. And I think I've got that slide maybe after this one. I'm going to talk about Boudin a little more first. He was a very humble man, was born on a farm outside Paris. It's not quite clear from historical records how he ended up going to medical school, because he didn't come from a family of significant means. But he took an early interest in obstetrics and wrote his MD thesis on cephalopelvic disproportion. Subsequently went into practice and focused mostly on obstetrics. He was a resident in Tarnier at the Paris Maternity Hospital. He went and studied with Lister and learned about asepsis in Edinburgh in the 1870s, and then he succeeded Tarnier as the head of the maternity hospital in 1895. And these two individuals were responsible for two things that were really critical and are still critical today. One was the incubator, but the other was that they came up with the first graduated feeding device with a soft tube that could be passed down into the baby's stomach. And before these, they would use things like they had nasal spoons that they would put the spoon in the baby's nostril and drip the milk through the nose, which is not maybe the safest way to feed a newborn, and I expect aspiration was a complication of that. So the incubator and the graduated feeding device, and then when Boudin took over for Tarnier, he designed what really is, it was the prototype for the first modern neonatal intensive care unit. It's got isolation rooms. It's got back then he was a key proponent of breastfeeding, using breast milk, but premature babies, small babies, too young to nurse. So he had a dormitory for wet nurses who would pump and take and go down and feed the babies in the nursery. So this was really the prototype for the first neonatal intensive care unit. And if you read his book, which he published towards the end of his career, there are these beautiful graphs that show survival. This is actually mortality, not survival. So these high numbers reflect babies that died, but these are percentages that died based on admitting temperature and birth weight. And so the babies that had an admitting temperature of less than 32 degrees, these are the smaller infants on the left. Larger, I think these are over 2 kilograms on the right, but you can see there's a marked difference in mortality based not only on admitting temperature, but also on birth weight. And that's no surprise to us, but he was the first one to really start to quantitate and measure this. And then he also looked at inborns, which are the red bars, versus outborns. You can see the difference in mortality is profound in inborn babies versus outborn babies. And even in the early days of my career, Dr. Wells' career, when neonatal care in smaller hospitals was not really up to the level it is now, the outborn mortality was significantly higher because they really weren't equipped to begin to keep the baby warm and provide the kind of care needed to stabilize until the transport team would arrive. And these graphs are really, I think, beautiful. They look a lot like the little newborn weight graphs that we used in the nursery when I was a fellow. And so this looks at weight gain and milk intake. And you can see these really look a lot like the birth weight and postnatal weight gain curves that we were used to seeing with babies that we would take care of in the nursery. And then these are straight from his book, and his book is really, it's kind of an early masterpiece of work in this area. And these are the mortality statistics that they reported out, comparing mortality in 1879, 1880. This was pre-incubator, and then looking at it a year later when the use of incubators was routine. And you can see there's almost a 50% reduction in mortality just from keeping babies warm. So a very important and remarkable discovery. And then he authored, he went on to author what was really the first textbook of neonatology. And you can get this reprinted at Amazon, and it's really a fascinating read. And it looks at, this is a little fuzzy, but it's the feeding and hygiene of premature and full-term infants. So the first half of the book's devoted to prematures, and the second half is devoted to full-term infants. And it's really just fascinating to read and kind of trying to put yourself in the mindset of what was it like, to be a doctor taking care of really small babies at that time when technology really had not really begun to influence care to a significant degree. And this is the introduction from his first chapter, and I think it kind of sums up what they were faced with. Infants enfeebled by premature birth should be guarded with special solicitude. Not only do they share to a greater extent than full-term children the ordinary risks of infancy, they labor under a danger which in its intensity is almost peculiar to them. I refer to the great readiness to which they become fatally chilled. With weaklings, we shall have to consider 3 points. And so his book went on to focus primarily on keeping babies warm and nourishing them appropriately, and then several chapters on the diseases to which they dealt with. And back then, a lot of it was diarrhea and vomiting, and babies that had significant respiratory issues, they were really kind of put aside because there just wasn't anything they could do for them. But those are the 3 areas that his text focuses on. And so his approach to the nursery environment included grouping the sick babies and the well babies in separate areas, separating the wet nurses' babies who they had their own infants to take care of. They would separate them from contact with the prematures. They had a milk room for storage and preparation, keeping the bottles sterilized of milk in a cool location during the warmer time of the year, and then providing appropriate dressing and washing area for the nurses that would take care of the babies. And this all looks very modern, based on what we still do now. And his key contributions were the importance of maintaining normal body temperature, providing adequate nutrition, and he was the first really key proponent of using breast milk. And I'll talk a little bit later about how that his early advocacy for it really faded for almost 50 years, and even into the 1960s, formula was really the standard until there was some additional investigations done. Trying to keep mothers and infants together, and they had a little follow-up clinic for mothers and babies that they would follow them out to several years of age. So that again sounds very modern, kind of like what's been done in modern neonatal intensive care during our time in practice. And then I'm going to shift gears now to talk about, anybody heard of Martin Cooney? He's kind of an interesting character. He was a student with Boudin in Paris. His Paris days, there's a lot of historical haze about what happened then. But he did study with Boudin in Paris, and then there was a German named Alexander Leon who designed what really was a kind of a more modern-looking incubator. And back then, there were the way technology was exhibited. There were these world expositions that were in big cities all over the world: Paris, Vienna, Berlin, London, and eventually in the United States. And they would exhibit new technology at these world expositions. And so after Cooney after he studied with Boudin, he was a little bit of an entrepreneur. He partnered with Leon to exhibit live babies in Leon's new incubator in Berlin, in London, and eventually in the United States. And this was how new technology really got diffused. There weren't detailed people who came out and told you about it. You went out to these shows and saw it. And so this is really how the incubator began to get out into a little bit more of the mainstream in terms of being used in places that where mothers and babies were. And Cooney eventually immigrated to the United States and had incubator exhibits in multiple places across the U.S., Buffalo, Chicago, St. Louis, I think maybe one in Nashville, Philadelphia. And they would have buildings there, and you can see infant incubators, and it says under there with living infants. And these were really like, they live like sideshows, which, you know, you can kind of look at that a little askance, but it was a different time. And you know, the fate of babies taking care of these would probably have been to die wherever they were born. They would be born somewhere, and somebody would go, we can take them out to Dr. Cooney's building. And they would go out there and get free care until they were ready to go home. So it really kind of a fascinating tale about how, you know, incubators began to be used, and it wasn't in hospitals. It was in places like this. And he ran an incubator concession at Coney Island for 40 years, 40 summers. And they would endure fires. The place would catch the Coney Island place would catch on fire. They'd have to rush the babies out, you know, to keep them from being killed in the fire. And then they'd rebuild, bring the babies back. It's quite a saga. And there's actually a book written by an investigative writer that I have as a reference. Who, if you want to read more about Dr. Cooney, really fascinating tale about his career. So the incubators were first demonstrated in these exhibitions. This is the building at Buffalo. You can see very modern-looking incubators along the wall, attendants there to take care of them, and then the railing to keep the patrons flowing through. And this went on for about a decade in the U.S. So sideshows were really, in a way, the first neonatal intensive care units in the United States. And this is an image from his incubator exhibit at Coney Island, and you know they took this quite seriously. And they would have reunions and invite the babies back. They would get diplomas. I think we might have been given diplomas out at one time when I first was working in the NICU here. And for Cooney, it was a family affair. This is his only daughter, who was a nurse that worked with him in his Coney Island location. So that's a little bit of a kind of a side story, but really a fascinating and kind of important story to how incubator technology began to get out more into the mainstream. Now I'm going to go now to Chicago and talk about a pediatrician named Julius Hess. Graduated from Northwestern right at the turn of the century, and then interned in Chicago, and then went to study pediatrics at Hopkins. And actually, he went overseas for a while too. I think as most doctors who wanted to be well trained at this era in the U.S., most would go overseas for a year or two. And he had a horse and buggy practice in Chicago. And at the Chicago exhibition, he went to the incubator exhibit, and he and Cooney actually became friends and kept in touch with each other. And in that way, Cooney's work actually had significant impact on what Hess went on to do in Chicago. And he established what was really the first neonatal intensive care unit in the United States. He called it the Premature Infant Station in 1922, and he designed what was really the first kind of modern incubator designed by someone in our country. And in the early one, they even had would even have a little supplemental oxygen tank for some of the babies. And I'll come back a little later to talk about oxygen. But he emphasized the teachings of Boudin and his approach, and he cared for over 9,000 babies over 30 years, and 3/4 of them survived. So a pretty remarkable individual. He also wrote the first text, what I would consider modern text of neonatal care, really anywhere in the world. Kind of a successor to Boudin's The Nursling. and he designed a little transport incubator that would go out and pick babies up wherever they were born and bring them to his premature infant station. So he was a real pioneer and really considered the first modern neonatologist in the United States. And he published his series in the early 1950s, and this is his survival statistics, which there's nothing to really compare them to, but this was the first really large series. This was 30 years worth of work that he published, and there was really nothing approaching it anywhere else in the literature at the time. So he was a real pioneer in starting a NICU and in kind of maintaining careful follow-up numbers with how they were doing. Now, I want to pivot next to talk for just a second about development that wasn't really related strictly to the NICU, but it did have, it had some downstream effects. And, there was not much in the way of federal presence in healthcare at all in the early 20th century. State healthcare was all state, local, city, and as part of the progressive era legislation, that there was the founding of what was called the Children's Bureau, and its mission was to report on all matters pertaining to the welfare of children. It was established in 1912. It was the first federal agency to focus on child health and welfare. So in that way, it was very important to the development of pediatrics. And it had a first-year budget of just over $25,000. And it would eventually evolve into the Office for Child Development in what is today the Department of Health and Human Services. And Julia Lathrop was the first head of the Children's Bureau, and she was the first woman to head any kind of federal agency. So she was a real pioneer in that respect. Now, I'm going to connect the Bureau to her in just a minute, but I want to talk now about a woman physician, Ethel Collins Dunham. She got her MD at Hopkins in the early days. She was the first female house officer at what would become Yale New Haven Medical Center. And she focused in her career on newborn care and follow-up. The first woman appointed professor of pediatrics at Yale, and she was eventually appointed chief of child development at the Children's Bureau. And interestingly, one of her classmates at Hopkins was Martha May Elliott. Has anyone heard of her? She was a very early pioneer in particularly pediatric public health. And really had quite a remarkable career. They were not only classmates at Hopkins, they were life partners at a time when that was not a thing that you saw, or saw certainly people of any importance that was the case. So they were pioneers in that respect, and both really had remarkable careers in pediatrics. If you want to read more about one or both of them, but the connection I want to make is that Dunham wrote some very detailed guidelines, standards, and recommendations for hospital care for newborn infants. And the Children's Bureau eventually published this. And this became the boilerplate for the guidelines for perinatal care, which the AAP adopted and publishes regularly. And really, those are the guidelines for care of newborns. So Dunham's work and her publication really was the groundwork for what we use now, 60, 70 years later, as kind of the standard guidelines for the care for newborns. All right, I'm going to shift gears, and I'll get back to stuff that's a little more clinical. I put this slide in for Dr. Atkins, and she said she'd be here, but she said she was not going to be here, but she promised she'd be listening. So I'll have to ask her if she listened, because I wanted to ask her. Anybody want to make a comment on? These are the same slide. This is just a higher power, and it's a baby newborn with severe anemia. Anything about the slide strike you or interesting?
Hypochromia.
Yeah, and there are lots of these little cells. And these are nucleated red cells. And you can see they're all over the place. So this is a baby who has some kind of hemolytic process, and the bone marrow is just in overdrive trying to keep up with red cell production because red cell destruction is so high. And this is an image of a baby who has erythroblastosis fetalis, also known as RH factor hemolytic disease of the newborn. And this was a huge problem earlier, particularly in the 20th century. And the pathogenesis is the RH antibodies from the mom across the placenta lead to destruction of the fetal red cells, and the baby responds by trying to crank out more but can't keep up, and so we see hepatomegaly, liver failure, and all the other factors that result from that. And if the baby survives to be delivered, you see babies with ascites, edema, very hypoxic, placenta stick, boggy, polyhydramnios, and you have pleural and other kinds of effusions. And that's kind of a classic picture of what a hydrophic baby, probably a little bit premature, looks like. And this was a huge problem before a couple of measures came along to deal with it. And the complications of babies that survived the hydrops but then went on to become very jaundiced were some or all of these things. And these could occur at high levels, but they also could occur at low levels, particularly in prematures. So the level of bilirubin that causes toxicity is not necessarily high. It's related to the gestational age, serum protein status, and a number of other factors too. There's a pediatrician at Boston Children's in the 1940s, Louis Diamond, and he was the first physician to perform an exchange transfusion using an umbilical vein. The umbilical vein had actually been catheterized 20 years earlier. This is James Sidbury, who he did it in a small hospital in Wilmington, North Carolina, and subsequently wrote a little paper about it. And it just kind of, I guess, it just didn't get into the mainstream literature enough for people to know about it. But Diamond resurrected it. There had been exchange transfusions done before this time, but when I went back to read about those, they were done, the manner those were done in, blood was infused through like a saphenous vein or something like that, and I couldn't believe it. It was withdrawn from the sagittal sinus, which just seems impossible. It's good the residents don't have to do that these days. I'm not sure what made the light bulb go on for Dr. Diamond, but the umbilical vein is a much safer and easier method of access than the sagittal sinus is. And you can see that, mortality pre-exchange or survival pre-exchange was only 10%, and post-exchange it went up to 70%. So exchange transfusion had a huge impact on mortality from RH incompatibility. And I'm going to come back and talk about this because RH incompatibility, exchange transfusion, that has changed over the time, certainly the time that I've been in practice, and some of the other ones here. So I want to move on now to talk about oxygen. Now, oxygen was administered in kind of a random, haphazard fashion early in the 20th century. And they would basically, like the Hess bed, they would just hook a tank up to the incubator and turn it on, and the baby looks better, and they just kind of leave it on for a few weeks because there was no way to monitor oxygen amount in the incubator. There was no monitoring of blood oxygen in the baby. It was totally empiric. So the incubators some of them were pretty airtight, some of them were pretty leaky. So some babies probably had pretty high FiO2s, and some babies had pretty medium or low FiO2s. Just a very crude way to administer oxygen. And gradually the incubators became a little more airtight, and pediatricians started to give oxygen a little more liberally because I assume they noticed that it seemed to help, that the babies that stayed pinker seemed to do better. And then in February 1941, a Boston pediatrician, Stuart Clifford, made a house call to see a 3-month-old. who had been born a couple of months early. And the quote in his paper was, although the baby's general development was excellent, I was shocked to see roving nystagmus and opacities in the eyes. I had to tell the family I was afraid the baby could not see. And then the baby was examined by an ophthalmologist who noted that there were grayish membranes covered with blood vessels on the posterior aspect of the lens. Does anybody know what this is? Yeah, this is the first reported case of retrolental fibroplasia. And that's kind of a black and white of what they do. You just see a gray reflex when you examine the eyes. And then a week later, he received another call from a different family, and a family member had noted the eyes were behaving strangely. So this is just a week apart. And he made another house call, and the baby's eyes looked exactly like the first baby's. And then he was examined. This baby went on to be examined by an ophthalmologist. Interesting, this baby was a twin. It must have been SGA. The other twin died, but it was a twin, just a kilo baby. So it's probably a 34-week, just really SGA baby, which is just kind of an interesting aside. But an ophthalmologist at the Massachusetts Eye and Ear Infirmary, he examined the second of these two infants. And then after he saw 3 other cases, now 5, he wrote kind of very presently, in view of these findings in 5 infants born prematurely, perhaps this complication should be expected in a certain percentage of premature infants. If so, some new factor has arisen in extreme prematurity to produce such a condition. And then shortly thereafter, another Boston ophthalmologist coined the term retrolental fibroplasia. So this is kind of the origins of what we now call ROP. And Terry went on to collect over the next several years 117 cases of this new eye disorder. And this, I'm distilling this down pretty concisely. The true saga is a real fascinating read. But I want to give you the highlights. The oxygen RLF connection, there were, for about 10 years, it was kind of total confusion worldwide, because other hospitals started to report this, not just the United States. And the focus was on what was new and different in the care of prematures. The prevalence was incredibly variable from nursery to nursery, and there'd be nurseries with high prevalence, nurseries with low prevalence. Some countries it was higher than others. I don't know if the incubators were just leakier in some places. You don't know. And there were a lot of other new things that had been introduced in newborn care during this time. There were new vitamin preparations, supplemental iron, oxygen, feedings had changed, and they really did not know what was going on. But oxygen was clearly in the mix as far as a suspect. And so there was an observation made in England. This is Vicky Cross, and she's kind of Julius Hess's equivalent, except she was in England. She started the first NICU in England and wrote the first British textbook on neonatology. And she's kind of a real interesting woman to read about, too. Very, very early pioneer in the field. And she noted that during the year 1949-50, 10% of the babies in the nursery developed blinding RLF, and they hadn't seen any in the previous 16 years. So what was different? Well, what was different is in 1948, the year before they saw the RLF, was they had gotten 2 modern American incubators that were really airtight and could sustain high levels of supplemental oxygen. So the hunt was now on for, it looks like oxygen at least is one of the factors that we need to try and understand better. And so there were reports from all over the world about oxygen. Some showed an association, some didn't. There was a really important report from Australia that kind of indicated that there was. By 1952, 10,000 infants worldwide had been blinded secondary to RLF. So it was a true epidemic. And then a group of ophthalmologists and pediatricians, it's still remarkable to think about how they made this happen, but they were able to get together 18 hospitals in 1953 and conduct a randomized trial to see what was going on. Was it oxygen or something else? And so they randomized to routine oxygen and curtailed oxygen. And you can see that in the routine oxygen group, the incidence of RLF was more than twice what it was in the curtailed, and the incidence of scarring RLF was about 4 times what it was in the curtailed. Now, one of the great fears about restricting oxygen would it increase mortality? And because of that, they were very careful about this study got monitored kind of like modern day trials do. They were looking periodically just because they were afraid that ROP might be less, but there may be more deaths in the babies that had curtailed oxygen. Well, that did not prove to be the case. And this was the first randomized trial almost of any kind done in the United States that was a truly randomized controlled trial to try and study two therapies. So in that way, pediatrics really has always been at the forefront in addressing questions in this fashion. So that's all I'm going to say about ROP. We've learned a lot about it, and it's much less common now, but that's almost another grand rounds if one of y'all wants to do that. Who was the first woman to enter the field of anesthesia? Made and played her own violin, went to graduate school after she retired, decided she wanted to learn how to fly after she went to graduate school, and she created a scoring system to assess the adaptation of the newborn to the outside world. Yeah. And I talked about Virginia. I did a talk on some important pediatric individuals a couple of years ago, and if you want to read about a truly remarkable person, she played on like 8 college teams, and she just was just an incredibly talented woman. Anyway, I encourage you, if you're interested in reading about her, do it. She's a remarkable. She could be a grand rounds by herself. And her paper describing her study was published in 1953. And it is said that she outlined it on a hospital napkin. And that actually a medical student asked her, some of this might be, we're not sure how true it is, but it said that a medical student asked her, well, Dr. Abrar, what things do you look at when you assess a newborn in the delivery room? And so she wrote the 5 things out on a napkin, but unfortunately, the napkin has been lost to history. So it'd be great to have that napkin. But these are the 5 things that are a part of her score. And, her score is still the standard way to assess a newborn in the nursery 70 years later, or in the delivery room 70 years later. And it really, probably, that there are a lot of benefits from her score, but one of the big ones was it forced people in the delivery room to actually pay attention to the baby. In more than, the baby looks like he's doing okay. Instead, they had to actually go through some thinking about, why is the baby doing okay? What are we looking at here? So her score really, I think, changed the delivery room environment in terms of making the folks that were there attending the mother and the baby pay more attention to the baby. So read a little bit more about Virginia Abrar if you get a chance. I'm going to move on now and talk about light. And there was a hospital in Essex, England, and this is Sister Jean Ward, who is not completely lost to history. She's worth reading about too. But the registrar, who would be the neonatologist in charge of the nursery, wrote that the sister in charge of the premature babies unit had earlier reported the apparent fading away of the yellow pigment of the skin in jaundiced babies when they had been for a short time in sunlight. They would take the babies outside and let them kind of be in the sun because fresh air felt to be good for them. And she began to notice that, these babies that are in the sun a lot, they're not as yellow as the babies that are not in the sun. And so the registrar and a couple of people he was working with designed a study, and they noted that Sister Jean had reported this observation, and so they decided to expose jaundice babies to sunlight and to assess the results by serial bilirubin determination. And this is what they found. And the image on the left is bilirubin after periods of sunlight exposure, and you can see that after 2 hours, there's a nice drop, and then a rebound. After 4 hours, there's even a bigger drop, and then a less of a rebound, and then another 2 hours, there's a drop, and it continues to go down. And so they went on to design a light source to perform the same kind of analysis, and were able to show that artificial light can reduce jaundice as well. It's too bad research isn't this simple now, that you could just notice something. And as I'm going to show you, it's interesting how what seems to be a very important observation took some time to get some traction in practice. And I'm going to come back to that. I want to touch base on this quickly before I get back to light. This is a study that was done around the same time, the 1950s, and it was actually done to look at two antibiotic regimens, and was one superior to the other. Infection was more of an issue in the nursery in those days, and antibiotics were kind of new, so they were kind of experimenting with different antibiotics regimens to see, does antibiotic regimen A better than antibiotic regimen B? So anyway, that was what the study was designed to show, or to look at, was difference in mortality between antibiotic regimens. And William Silverman is, to say that he's a giant in pediatrics is not giving him enough credit. He was the first pediatrician to take using randomized clinical trials seriously, and kind of spent his whole career trying to get us to be better scientists when we study new therapies. He's an interesting person to read about too. But at Babies Hospital in Columbia, 54-55, they randomized 193 babies to 2 antibiotic regimens. And I know these look completely crazy by current standards, but they weren't crazy in 1954. And the primary outcome measure was mortality under 5 days and mortality after 5 days. And what they found was in the tetracycline group, and these babies were randomized to the 2 groups, deaths less than 5 days, there were 20. Deaths in the pen-sulfa group were 46. They did a lot of autopsies back then. Autopsies confirmed kernicterus was rare in the tetracycline group, was common in the pen-sulfa group. There was no other difference in mortality between the 2 groups. So that's mortality less than 5 days. Mortality over 5 days, kind of the same picture. 7 deaths in the tetracycline group, 14 in the pen-sulfa. Autopsies, no kernicterus in the tetracycline group. More than half the babies in the pen-sulfa group had kernicterus. And there was no difference in mortality or in diagnoses between the 2 groups otherwise. This study was done before the whole bilirubin binding albumin. None of that stuff had really been figured out yet. But what they did figure out was there's something about about the pen-sulfa antibiotic regimen that significantly increases the occurrence of kernicterus. So this study sparked a tremendous amount of interest in, what's going on here? What is it about that antibiotic regimen that leads to such a significant increase in kernicterus? And it also raised this whole issue of that, new treatments for infants really need to be studied carefully before they become routine. All right, so getting back to when did the lights come on in the United States? Well, this is a quote by a famous American neonatologist. In 1958, I read the original article on phototherapy by Kremer et al., but was unimpressed. Numbers were small, needed confirmation. I didn't think much about phototherapy, and apparently neither did the British or the North Americans. And that was this physician's quote in 1965. You might recognize the lake. It's Lake Champlain, which might be a tip to who this is. So in 1965, a pediatrician from Santiago, Chile, arrived in Burlington, Vermont to do a fellowship in neonatology. And after ran it for a couple of weeks, he asked the chief, "Why aren't you using phototherapy?" And the chief replied, "Is anyone using it?" And Pierre replied, "We're using it in Santiago, and it seems to work." So his chief dispatched him to the library to find some literature to support the use of phototherapy. So he went to the library, and he found over 20 articles that documented the effectiveness of phototherapy, but they were all published in French, Italian, Spanish, or Portuguese. And so the neonatologist was Dr. Gerald Lucy, who was the editor of Pediatrics for 35-plus years, and kind of a giant in the field of neonatology. And they designed a controlled trial of phototherapy for the prevention of hyperbilirubinemia in premature infants, and it clearly shows that it works. So the lights came on in the United States after this study, and Dr. Lucy decided that he would start keeping up with the international literature as well as the English language literature. And I found this slide because I wanted to show y'all, but between ROGAM and exchange transfusion, this is the incidence of exchange transfusion. It's based on population per 100,000 live births, and these are premature. These are full-term infants and premature infants. So 57, 61, 88 to 97, about the same time period. I guess that's a little bit later. But you can see exchange transfusion has vanished. It's just because of ROGAM and phototherapy. Anybody here done an exchange transfusion that's under the age? Anybody under the age of 60 that's done an exchange transfusion? A couple. Preston Vargas, he was a faculty member here for many years. He was a neonatal fellow at Duke, and he dabbled in neonatology a little bit here. But he told me once when he was a fellow at Duke, he did 99 exchange transfusions. There are probably not 99 exchange transfusions done in the whole United States now in a year. But that just shows you how profound the impact of ROGAM and phototherapy have been. It's a rare procedure now. I'm sure residents rarely do them now. Fellows might have to fight over them because you only get to do one or two during fellowship. So, all right, moving right along. So that's kind of the big items on bilirubin. Atelectasis neonatorum, which is also known as hyaline membrane disease, increasing focus of interest during the 1950s. And this was kind of the classic ground glass looking image of a baby chest x-ray with hyaline membrane disease, and these are the hyaline membranes lining the alveoli of a baby that died from it. And I think that the fact oxygen could be administered, that was helping. Neonatal care was evolving, so there was interest in kind of, what can we do more to help these infants? Well, there was a study in 1958-59. This is Mary Ellen Avery, who was kind of an early woman giant in neonatology. Virginia Apgar was an anesthesiologist. She really wasn't a neonatologist. But Dr. Avery was a research fellow at Harvard, and she was very interested in respiratory disorders. And she did a very small but interesting study which looked at surface tension from lung extracts from babies who died from causes other than hyaline membrane disease and babies that died from hyaline membrane disease. And you can clearly see the babies that have died from hyaline membrane disease had much higher surface tensions than the babies who died from other causes. And this was the first hint of what was going on. And all the research we have artificial surfactant now because of this is the study that kind of got all those wheels in motion. The other thing that got things in motion was that there began to be interest in providing artificial ventilation in the 50s. And the polio epidemics of the 50s were a real stimulus for this. There were large polio outbreaks in the U.S. in the 50s and actually worldwide. That the strain had a high prevalence of causing paralysis. So there was a real interest in trying to provide assisted ventilation to help these patients survive. This is an image of a nurse taking care of an infant in a negative pressure ventilator. And early on, it was provided by, they would do intermittent positive pressure by mask. They would use negative pressure devices, positive pressure ventilators, and all of these began to be used and outcomes assessed. And this continued into the early 60s, and then in 1963, Mrs. Kennedy delivered a premature infant boy, Patrick, who was kind of a big preemie, but he died at 48 hours of age of RDS. And this was a huge, I mean, this got the pediatric research community just super energized to try and figure out, you know, we've got to be able to do better than this. That was not a medical kind of event in terms of somebody discovering something, but it was a social event that had a huge impact. And then there's a little bit of a Roanoke connection with the treatment of RDS. There was a tech professor in the early 60s, Professor Leon Arp, and his son had been affected by RDS in the early 60s and survived. But this inspired him to begin working on ventilators suitable for infants, and he designed a ventilator and conducted a trial at Roanoke Memorial in 1966 and 67 and published 2 papers from it. And he treated 101 infants with hyoid-membrane disease RDS. 86% survived versus 67% with historical controls. And he published their work in anesthesia and anesthesia. And this is one of our nursery nurses of the day, and there's the ARP ventilator. And this was actually a face mask ventilator, not an endotracheal ventilator. So there was a fitted face mask, and they received intermittent positive pressure ventilation via that. And this is the mom of one of his early patients in his ventilator. And you know, it's interesting to speculate why his ventilator, it did not, had he been at a bigger center, would his ventilator have gotten more into the mainstream of ventilators used for infants? We'll never know. But there is a nice, interesting connection that we have with the development of mechanical ventilation for neonates. And then a few years later, this is a paper published by Northway and his group, and it describes 17 infants with a form of chronic lung disease following mechanical ventilation. This was the first report of bronchopulmonary dysplasia, and kind of a little bit of a warning that this may not be as simple or as safe or as easy as we think it's going to be. And it's taken about, I mean, this was 67. It probably took 30 years to really sort out the BPD and figure out what was the best way to ventilate a baby to reduce the incidence. And artificial surfactant supplementations had a role in that too. And then to wrap up with kind of the historical things I wanted to touch on, this paper was published in 64, and I wanted to come back to feeding. Because feeding had really evolved away from breastfeeding, and it had evolved, or breast milk, and it evolved away from like feeding early. You know, babies. The story of infant feeding is kind of a grand rounds by itself. But feeding late had become the norm. You're feeding at 2 or 3 or 4 days of age. So this is the introduction from this paper written by Victoria Smallpiece, Pam Davies at Oxford. And the timing of the premature baby's first feed, and no less its content, has for some years been controversial. During the 40s, the hazards of aspiration, presence of edema were advanced as reasons for starving the infant. Although in the past few years starvation has been less rigorously practiced, premature infants are seldomly fed intensively the first few days. And then I think the last statement really kind of hits home. The placenta nourishes these infants continuously until they leave the uterus. It seems irrational to interrupt the process when the infant is exposed to greater risk. And so they did a little study where they took 119 infants between 1 and 2 kilos, passed a feeding tube, started feeding at 2 to 3 hours of age with breast milk, and then they would advance the feeds up over the first 4 days, and then they had a group of controlled infants that were same birth weight, earlier time period. And this is what they showed, that days to regain birth weight, early feeding, it was a little bit faster, and that they had a later fed. These were at several days, and these were like 4 or 5 days. Meconium was passed earlier. If you were fed sooner, your bilirubin was lower. And the one thing this really helped is that it showed that it wasn't dangerous to feed babies early. And I think there was just this fear of, if we feed too early, something bad's going to happen. And this study showed that, in fact, nothing bad's going to happen. There are positive effects from it. And this study kind of got neonatologists over the hump of, maybe feeding early maybe that is better. And that's what we do now. That's the way we approach nutrition now. So this was a very important paper published in 1964. Now, what I haven't touched on and what has happened since then, there's a lot. You can analyze small blood samples. There's new materials and catheters. There are better machines and ventilators. I haven't touched on surgery and anesthesia, very important. All the non-invasive monitoring, and then understanding how birth weight and gestational age play an important role. Neonatal care is more gentle. It's more physiologic, the respiratory support. Nutrition is much better. Parenteral nutrition came along. There are fewer ups and downs in the nursery. The environment is calmer. When Dr. Wells and I were working in there, it was like chaos. It was like sensory overload for the babies, the nurses, the doctors, the respiratory therapists, everybody. And that's really changed. Care's been regionalized. There's transport for mothers and infants. We've addressed or have started looking at ethical issues, dilemmas, decision-making, and outcomes have improved. So there's a lot that's happened, but it was really dependent on the things that came before it. And so returning to Pierre Boudin and his approach to care, attention to temperature and environmental management, nutritional support, breast milk is key, management of the common clinical conditions. They're a little bit different from the ones he faced. But his core principles are still the key things that we pay attention to in the NICU. If you want to read a few things, this is a nice reading list. This is Silverman's book on RLF, which is just a fascinating read, and this is Dawn Raffel's book on Martin Cooney, which is a really interesting read. And if you want to read more about Sister Jean, there's a nice article about her. So I think I've got to do some questions. Right, Jean. All right. Question 1, Pierre Boudin emphasized all the following in the care of weaklings except careful attention to maintaining body temperature, understanding the diseases that weaklings were predisposed to, feeding with breast milk, liberal use of oxygen. All right. You're all doing great so far. Which of the following contributed to the epidemic of RLF in the 1940s? Use of incubators that were increasingly more airtight. Careful monitoring of inspired oxygen to maintain levels of at least 70%. More liberal use of supplemental oxygen. More monitoring of oxygen content in order to maintain PO2 greater than 100. There can be more than one answer to this question. Yeah, A and C. Better incubators and more liberal use of oxygen. And which of the following is a true statement about bilirubin and phototherapy? High levels of bilirubin are not associated with serious effects. Phototherapy was widely utilized after its effects were discovered. Toxic effects of bilirubin are only observed at very high serum levels. The discovery of the effect of light on bilirubin was made by an observant nursery nurse. All right, y'all got 100. And that's the end. Questions, comments? Dr. Wells is here to reflect on, we could call him the founding father of neonatology in Roanoke.
Is that somebody I know?
Yeah. The baby in this picture is a graduate student over at VTC now. So. Yes, sir.
When Virginia Apgar first published her scoring system, did she lay it out in the mnemonic in her last name, or was that somebody else attributed that to her and put it in the AP?
Yeah, that's right. The question is, did Virginia Apgar lay out the Apgar as the mnemonic for her score?
Right.
The answer is no. A neonatologist, Joe Butterfield at University of Colorado, Denver, came up with it. If you're interested, go back. The readings are, the AP's published a series of articles of historical interest, and it's these two collections. If you want to read more, and Jeff Baker, he's a medical history person at Duke, and he was a med student in the nursery when I was a fellow. And this is the definitive book on the rise of the incubator. If you want to read more about, you know, coming from the earliest days to what we use now. All right, good, thank you.